So the next hemolytic anemia will be a G6-P-D deficiency. So G6-P-D is this is actually involved in the glucose metabolism. Okay, this enzyme, glucose 6-phosphate dehydrogenase. So this is again an intracorpuscular defect only, but again an inherited intracorpuscular defect, but it is an enzymatic defect. So till now we had seen about the membrane defects. Next we are going on to the enzyme defects. This is inherited as a X-linked recessive disorder. So X-linked recessive in the sense males are going to be affected and the females are going to be carriers, right? So what happens normally with this G6-PD enzyme is that it is going to convert the glucose 6-phosphate into 6-phosphogluconate. So during this reaction, it is going to convert NADP to NADPH because it is a dehydrogenase enzyme, right? So hydrogen is going to come out. So NADPH is going to be formed. So when this NADPH is reconverted into NADP, it is going to convert the oxidized form of glutathione into reduced glutathione. So GSH is the reduced form. So oxidized to reduced glutathione is going to be formed during this conversion again. So this reduced glutathione is used up when the free radical H2O2 is getting converted into H2 water. Okay. So H2O2, it is going to be removed, right, by either the catalase enzyme or using this glutathione peroxidase enzyme. So GPX is the enzyme which is going to catalyze reaction, glutathione peroxidase. Okay. So during this procedure, this reduced glutathione is used up. So this free radical is going to be degraded into water. So this is what happens normally. So G6-PD is actually protective against the free radical injury. Okay. And it is going to help in maintaining the reduced glutathione levels. But when this enzyme is deficient, none of this is going to happen, right? So NADPH is not going to be formed. So reduced glutathione is not going to be formed. When reduced glutathione is not formed, it cannot convert H2O2 into its into water. So H2O2 is going to be active. It is a free radical, right? So when this free radical is there, it is going to cause the oxidative stress. So when there is oxidative stress, it could either directly destroy the RBCs in which the oxidative stress is happening. So this reaction, this G6-PD reaction happens in the RBCs as well. Okay. So this oxidative stress is going to destroy the RBCs. So this can result in intravascular hemolysis. Apart from that, this oxidative stress can denature the hemoglobin present in the RBCs. So denatured hemoglobin in the RBCs are going to form Heinz bodies. So Heinz bodies are nothing but denatured hemoglobin only. When this Heinz bodies containing RBCs are going to enter into the spleen, what happens is the spleen is going to take a bite of it. It is not normal, right? There is something inside the RBC, so it is not quite deformable. So it is going to form spherocytes again, and the part which contains this Heinz body will be eaten up by the splenic macrophages. So it is going to appear as if a bite has been taken, and these cells are called as bite cells or degmacytes. Okay, suppose this was the RBC and there was this Heinz body, the macrophage would have eaten up this part and it is going to appear like this, a bite cell or a degmacyte. There is also blister cell formation, that is the same defect will be there, but there is going to be an intact membrane covering it. So it is as of appearing as if there is a skin blister. So these are blister cells can also be formed in this. So all of this is going to cause a repeated cyclism. It was going to cause spherocytes and this Heinz bodies. They are going to cause extravascular hemolysis in the spleen. So both intravascular and extravascular hemolysis is happening in G6-PD deficiency, but it is the extravascular hemolysis which is much more predominant. Okay, the most common one is extravascular hemolysis more than intravascular hemolysis, right? And this oxidative stress usually affects older RBCs compared to newer RBCs. Okay. So this is the image-based questions related to G6-PD deficiency. So these are the bite cells. Can you see this cell here is appearing as if a bite of it has been taken. So these are the bite cells, also called as the degmacytes. Then, and this is the supravital stain of Heinz bodies. So Heinz bodies, you see at the membrane, there is going to be a dot-like structure like this, stained blue in color. So these are the Heinz bodies. Heinz bodies are usually stained with supravital stains only. So even in that, it is usually better stained with the crystal violet and methyl violet rather than new methylene blue or Brilliant Crescent blue. Okay. So these are the blister cells here. If you see, there is some white color appearance at the end of this membrane, but still there it is going to be covered by the membrane. So intact cell membrane is going to be there, but some kind of whitish part is going to be there. It is looking like a blister. So it is the blister cells in G6PD. Then apart from that, spherocyte formation can also be there, as in when it goes into the spleen, it's forming spherocytes. So these are all the spherocytes which are formed. Okay, so these two are the spherocytes, and this is going to be a blister cell here. This is again a blister cell here. Okay, sorry, this is a bite cell here. Okay, so these are the characteristic findings, image-based questions in G6PD deficiency. So clinically, how do these patients present with? It is usually a self-limited disease. The only intermittent attacks is there. It is not a chronic disease. So it is going to be precipitated by certain oxidative stress. So that oxidative stress is going to be produced by either drugs like primaquine, ATT or sulfa drugs. Primaquine is an anti-malarial drug, while ATT, anti-tubercular drug, then sulfa drugs, any sulfa drugs, sulfonamides. Okay, so all of this is going to precipitate the oxidative stress, leading to hemolysis. Then fava beans consumption. So a particular group of people consume this fava beans, so that can result in G6PD deficiency, like a picture that is called as favism. Okay, then certain infections. So infections also can trigger oxidative stress, right, because of respiratory burst. So oxidative stress can be there, and that again can precipitate hemolysis. So the classical history will be an intermittent history, intermittent episodes of hemolysis, and not a chronic disease. So there are various variants of G6PD. Okay, so the B variant is going to have a normal T half of this enzyme, while the A plus variant is going to have a decreased T half, and the A minus variant is going to have much more decreased T half, and the Mediterranean variant is going to have the most lowest T half. So it is the most severe form of G6PD deficiency. So what are the findings in G6PD? So here again you can get a family history. So being a X-linked recessive disorder, you can get a history wherein males of the family are going to be affected. And then we have drug history. You can elicit for a drug history or intake of fava beans or any infection history. So all of this can give a clue to the G6PD deficiency. And CBC, if you see, the RBC indices are usually normal, but when there is lots of spirocyte formation, though the CBC in RBC indices can change accordingly. Okay, so peripheral smear, you see the same 4 findings. So you can see the present formation of spirocytes, Heinz bodies on supravital stain actually. Then we see bite cells or degmacytes, and then we see blister cells. Okay. So what is the test to diagnose this G6PD? You will have to, confirmatory test is to check for the enzyme level. So enzymatic assay for this G6PD should be there, which is going to be low. And then there is a screening test also called as methemoglobin reduction test. So MRT test is for is a screening test for G6PD deficiency. Okay, and in this they are going to use sodium nitrite. Sodium nitrite is used for reduction. Okay. So what is the treatment for G6PD deficiency? Being an intermittent disease, you can actually remove the precipitating factor. So it will go away by itself. So within 6 weeks or 3 months, it is going to resolve on its own. So you'll just have to give a supportive treatment till then. So removing the precipitative factor is going to be the most important thing. And as such, if you see, it is not a chronic disease, right? So in HS, it was a chronic disease. So even though anemia, jaundice, pigment stones, splenomegaly can be seen in any of the extravascular disease. So in this G6PD deficiency, you can still have anemia and jaundice and splenomegaly, but the pigment stone formation is not going to be there. Since it is an intermittent attack, you are not prone to develop pigment stones commonly, right? And as such, G6PD deficiency is going to be protective for malaria. So malarial parasites actually need this G6PD enzyme for their survival. So with this deficiency, these patients do not develop malarial infections, right?